That makes sense, Steve.
It's
Yeah.
kind of fun. All right. So, okay. So subretinal fluid. This is the chapter Dr. Pavin wanted me to talk about, which is this choroidal disorders. But I lumped it together. It's not. It covers a lot of stuff on subretinal fluid because now in the 21st century, we get OCTs and there's often subretinal fluid. So subretinal fluid. It's a dark area under the retina, easily seen on OCT. A lot of doctors' offices we deal with have OCT, but not fluorescein. So it's important to know how to interpret subretinal fluid. So first off, subretinal fluid is not always wet macular degeneration in an older patient. And that's important because everybody doesn't need shots. So there's a number of patients, it usually is, but it's not always. And in a younger patient, it's not always central serous. So you can't say you have central serous because maybe the person's got cancer. So it's important to be able to interpret subretinal fluid. So I was thinking about this, and this took me a while to put together. So I categorized subretinal fluid into these 6 different sections. First is a masquerade, where it looks like subretinal fluid, but it's not. The second is if fluid comes from the vitreous. Third is retinal vascular disruption. Fourth is if there's optic nerve edema causing subretinal fluid, like that patient we saw earlier. Choroidal disorders, which is the most common, and then cerebrospinal fluid, which is interesting. So we'll start with masquerade. So the first case I'm going to show you is a 75-year-old man who, starting about a week ago, thought he had a scratch on his eye, and he was getting some floaters. So he went to see someone, and they saw a problem on the OCT and sent him over to me, and this is the OCT of the left eye. So I'm not going to call on you, but you can see there's material under the retina. It's not dark like subretinal fluid is, but there's definitely subretinal material because you can see the RP in the back. And so what that is, here's a picture. It's a yellow spot under the fovea, and this is a pattern dystrophy. So it's a very common subretinal fluid, and some of the pattern dystrophies will look dark, so they'll have frank fluid. We showed a case a couple months ago where they actually had a fluid level in the pattern dystrophy. So the pattern dystrophies can look like subretinal fluid. It's probably not exactly fluid. It's probably more hyporeflective material. That's the first one. The second one is so that's a masquerade. Second one is it comes from the vitreous, as everybody knows is retinal detachment. So a 71-year-old guy with gradual vision loss, difficult transitioning from light to dark. He's got 2160 vision. The OCT shows a retinal detachment. OCTs are kind of nice for retinal detachment because you can see if it's submacular. You can see if there's anything a little weird about it. So I like, if you can get it, it's nice. It also can show that it's not, is or is not retinoschisis. This is something you should know and may not, is that after retinal detachment repair, it can take a long time for the subfoveal fluid to go away. And this is a patient, I dug through a lot of cases because I couldn't remember the name. And this is a 62-year-old person I did a pneumatic retinopexy on for a macula off. But this can happen with macula on detachment. Macula off detachment, in 1 week, the vision was 20/60, at 3 weeks, it was 20/50, and then at 5 months, it was 20/25, but there was still fluid. 9 months, still fluid, 20/25, and at a year, there was fluid at 20/25. And then finally, at 18 months, the fluid got away. David, you have an unpublished paper on this, right? Showing the laser makes it go away quick. So
Yes, unpublished paper.
Yeah, I love. All of us have,
it's an uncontrolled, unpublished small study.
I have a folder of unpublished papers. So there's laser can help this go away quicker. But if you read the literature, everything suggests that this is not detrimental to your final visual acuity.
You mean laser in the periphery?
Like laser around it, but I wouldn't do that because all the conventional wisdom now is that you don't need to because it goes away eventually and the vision gets better. Because you'll see these people who don't know this will take someone in at 6 months and say, oh my gosh, there's still fluid under the retina, we need to do something, but you don't. And the reason this is there is because, so this is the data. This is a pretty good paper, 2011. Macula off retinal detachment, and they said at 12 months, 17% eyes have fluid. So that's a whole year. 24 months, none of them did. In this, I usually put the N up, but I didn't. But this was a pretty good study on subretinal fluid and retinal detachment. The reason it stays is probably because it's so proteinaceous. When you drain subretinal fluid, you see how proteinaceous it is? And then when you concentrate it, and the reason protein maintains the subretinal fluid is because of the oncotic pressure, which we're not going to talk about, but I guess I will a little bit. So there's 2 things that move fluid are hydrostatic pressure and osmotic pressure. In the eye, osmotic pressure is oncotic because it's protein driven. So when you see fluid moving under the retina, it's almost always protein moving and fluid following it. I think it can be helpful to think of it that way. And that's why the smokestack, when you're seeing this on the central serous patients, there's probably protein leaking through that in the fluid. You've got disruption in the barrier. So retinal vascular diseases can disrupt the blood-retinal barrier, inflammation, infectious, infiltrative, neoplastic, and vascular. You need to know this. The inner blood-retinal barrier is the tight junction between the capillary endothelial cells. So there's a blood-retinal barrier at the level of the retina. It turns out there are other things that help with that. So all you need to know is, I believe, is the capillary endothelial cells, but also the astrocytes and Mueller cells contribute and the parasites contribute. It's important in two different diseases. The astrocytes and Mueller cells are probably important in macular telangiectasia because that's probably a defect in your Mueller cells. In diabetic retinopathy, the parasite contribution is probably compromised. But in all other things, it's just the endothelial cells, as far as we know. So this is an 82-year-old man, had cataract surgery with good vision and poor vision. So you know what that is. It's cystoid edema. He's been on drops for a couple months, not improving. Vision's not that good, and here's his OCT. So this is cystoid edema. So cystoid macular edema can cause subretinal fluid because there's a breakdown, the fluid's going through the retina into the subretinal space. It does tend to stay in the fovea, which is interesting. And same thing with the retinal detachments. When you look at those retinal attachments, the fluid tends to stay under the fovea. And I don't think anybody's discussed that I know of as to why. My interpretation of it is that the retinal capillaries are removing some of that subretinal fluid because the only thing in the fovea is the foveolae vasculars. The choroid, as far as I know, the choroid under the fovea is the same as the choroid next to the fovea. So the only thing absent in the center of the fovea is the retinal capillaries because of the foveolae vascular zone. So I think it means the retinal capillaries must be doing something to get rid of the fluid, and that's why you get into the fovea. Acute, so then this is a classic fluorescein for pseudophakic edema. You got the staining of the nerve and you got the staining of the macula, and everything was kind of leaky in the late frames. Go ahead.
So typically, I think I've seen pseudophakic CME with just intraretinal CME, but you can see subretinal.
You can see subretinal, and I think it's there was a very good paper that I looked for, and I wish I had a better memory, on the evolution of subretinal fluid and retinal vein occlusion. And it showed that in acutely you don't get it, you get it after a month or two. Okay. And it probably has to do with the disruption of the external limiting membrane, allowing the macromolecules through the retina into the subretinal space, driving that oncotic pressure to get the fluid there.
It's bad enough and it has enough time.
Yeah, exactly. And I think that's what it is. And the paper was interesting because it showed, it was very nicely done. And it was in ophthalmology, I can picture it.
Yeah, it's supported in the diabetic literature too.
Yeah.
If you look at diabetics with a known history of DME untreated, if they're chronic, so there's some kind of breaking point, like over 18.2 or 20 months, something like that, they develop subretinal fluid.
Yeah. So it has to do with, for retinal vascular, it has to do with the chronicity of the disease. Excuse me. So that's what this slide is. So if you look at leakage from the retinal circulation, it probably, it's exceeding the capillary's ability to absorb it and the absorption capacity of the RP. So you've got impairment in RP function may contribute, excessive leakage, so you get like so much fluid, or the chronicity, and it's a disruption of the outer retina. The external limiting membrane has zonular adherens, which are not quite as strong as zonular occludens. Zonular occludens are like blood-retinal barrier stuff. Zonular adherens are tight, but not that tight. So it's probably disrupting the zonular adherens.
Zonular occludens are in the RPEs.
Yeah, those are the RP, have the zonular occludens.
And there's no lymphatic system in the retina. That's one of the problems.
To help with the fluid. Then the optic nerve. There is a blood-retinal barrier at the optic nerve. I'm going to edit this out if I laugh. Okay, there is a because the name is kind of funny. It's the tight junction exists between the glial cells of Kunt, the Kunt intermediary tissue, pronounced that way, and they're continuous with the tight junctions of the RP. So if you look at the slide, it's over here. So here you have your Brooks membrane RP, and then you have that little intermediate border, which I think does sometimes show up on the boards. I don't know if that's too obscure for the boards. And then it goes into the external limiting membrane. So if that's disrupted, then you have fluid from the nerve can get over to the subretinal space. So optic nerve edema that's severe can cause subretinal fluid, which is like I think what we see in the neuroretinitis, the cat scratch patients. I think some of that is optic nerve fluid getting under the retina. So optic nerve fluid comes from blood, axoplasmic and interstitial. Axoplasmic stasis causes nerve swelling like you see in papilledema, And then the peripapillary subretinal fluid's common. Fluid all the way under the fovea isn't as common. This is a 33-year-old patient with nerve swelling, headaches, and vision loss, no fevers, and, oh, she has a cat, so it's another one of the cat and kittens ones. And this is the swelling of the optic nerve, which looks like the case we talked about today. This is not the same case because this is a younger patient. And so you see the swelling around the nerve, and then the swelling is getting under the retina. And it does look like it's, I mean, if you look at it, it looks like the fluid's coming off the nerve through the retina and under the retina because that's where it's thick. And then if you look at the ischemic optic neuropathy studies, some of them do have subretinal fluid. So there's a study showing that of 76 patients, about 10% had subretinal fluid just around the nerve, if you look at them right after the onset. So we've done, I should have done like Masquerade, Vitreous, Masquerade syndromes, Vitreous, Retinal Vascular, and Optic Nerve. The main one for subretinal fluid is choroidal. So that's what's in the chapter. So disruption of the blood-retinal barrier, which again, inflammation, infection, infiltrative, neoplastic, and vascular. And then there's a big list of choroidal disorders, and I'll put this up on the website, that can cause subretinal fluid, but it's not an infinite list. So when you see someone, because subretinal fluid can be scary. I'll show you a case at the end, which we don't exactly have a diagnosis on, and I saw another young girl where we're not quite at the diagnosis, where there's subretinal fluid, and it's not like it can be anything. It's somewhere on the list. It's either inflammation and VKH, which I have never seen. I don't know what it is about Tampa Bay and our 3 million population, but have you gotten any VKHs?
Yeah, we have a few.
It's not common.
Over the years, but not many. I mean, it's one every 3.
Posterior scleritis is one. And then infections. We had the unilateral idiopathic maculopathy a couple weeks ago. TB and syphilis can have fluid, but not always. Tumors, neovascular membranes is very common. A vascular insult, and again, the vascular insults cause choroidal leakage, but mostly they're disrupting the blood-retinal barrier, and then a fluid imbalance, which is the pachychoroidal spectrum now, which people talk about, which is central serous retinopathy and the other stuff. And I've not seen the mitogen activated protein kinase inhibitor associated retinopathy, but you'll see that in some cancer patients. I have had some patients on fancy cancer. I have a patient with, I think, an autoimmune eye problem from one of the anti-melanoma cancers. He's got a uveitis secondary. So there are all these fancy cancer medicines rolling out now. And then a staphyloma.
Posterior scleritis?
Yeah, up here. Yeah.
Okay. Next.
So that's a big one. So the outer blood-retinal barrier, and this you have to know. And this we've had residents who didn't know this kind of farther on. So please remember this. And I have not put any quizzes up, but I'll start putting some up because I think those are better board review than the last minute thing we did before. So the outer blood-retinal barrier protects the subretinal space from unwanted fluid from the choroid, and it's the retinal pigment epithelial cell. So it's the tight junctions between the RP cells and the cells themselves. So we also always talk about the junctions, but there's the cell membrane and the junction, so it's both of those. So you don't, just because you have a leaky choroidal mass, you don't always get subretinal fluid. There has to be a compromise of the blood-retinal barrier. This is a patient of mine with Sturge-Weber who has a choroidal hemangioma. I just said, he's a very good sport. I was like, we need some pictures. Like, okay. And he lets me put pictures of his face up too. But you can see the choroid's thick, and he's definitely leaking because he has a hemangioma, but there's no subretinal fluid. So the choroidal leakage isn't sufficient for subretinal fluid, which has always been a little bit of a mystery, I have to say, with central serous chorioretinopathy. Because we know there's a leaky choroid, but there's got to also be an RPE disease, and people have talked about that. And so here's his pictures. You can see the right eye doesn't have a choroidal hemangioma, the left eye does. Diffuse, it's kind of orangey, you can't see the choroidal markings, and he doesn't have subretinal fluid. So that's just to show. But this is the case we showed last. This is Dr. Eichenbaum's case of a choroidal mass. This is the one we all had a million pictures of. I think I used your pictures because you have that fancy scanner. So this is the osteoma, probable osteoma. And there's the same sort of mass, but it must be compromised in the RP and there's subretinal fluid.
Something to edit out if you choose to.
Yeah.
I have follow-up on his first Avastin injection. Nothing happened, like nothing. So I gave him a second Avastin injection. He's coming back either this week or next week to see if anything happened. If nothing happened after 2, we're just going to abandon injection.
Oh, well, that's good to know. I could leave it. Can I leave it?
Yeah. What's that?
Can I leave it that we tried Avastin and it didn't work? for the public to know in the video, or?
Didn't say, yeah, I did.
Oh, yeah, you can leave it. Sure, you can leave it.
Okay.
We've tried 2 Avastins on him. The first one didn't work.
Okay.
The second one is pending.
So it's probably not neovascular, it's probably.
It's probably tractional, yeah, or structural or
leakage
something.
whatever, yeah. Oh,
Yeah.
this is that kid, and this is the kid. Okay, so choroidal masses. Choroidal nevi are present in 5% of the population over age 40. Choroidal osteomas are super rare, and choroidal melanomas are 6 per million, and metastases are about 60 per million. Because we always talk about metastases being more common, but I figured I'd look it up so you'd have some numbers in your head. I do have 2 patients right now who have this problem. This is a 36-year-old female who's had a bunch of treatments in the left eye for about 6 years by another retina person. Avastin, Ozurdex, PDT, micropulse laser, so you know it's not me, I don't have that. And in the left eye is getting worse from her cataract. And this is her picture. And this is a subfoveal nevus. And I always like this case because I'll never forget, we had a grand rounds or fluorescein conference or grand rounds at Bascom Palmer when I was there. And this was the only case I ever saw stump almost the entire room, except for Dr. Gass, nothing ever stumped him. But it was just the nevus. So a subfoveal nevus can be very funny looking when you start looking at the imaging. In this patient, there was concern about the FAF. She probably has a pattern dystrophy too. She has these funny looking things, but she has the subfoveal nevus. And then you can see on the top of the nevus, there's that little spot, which is likely a neovascular membrane. It's just been leaking on and off. And I have another one with this now too. And it kind of comes and goes. So 25% of choroidal subfoveal nevi lose vision. It's either the nevus is leaking or there's a neovascular membrane and you get fluid over it. And, oh no, then there's the other thing, if you have fluid over nevus, there is a worry about transformation of melanoma, but I don't think that counts for these subfoveal ones. I just put that in there. So I think I treated her on and off with the shots, and she did recently have her cataract out, and she's doing pretty well. So this is a 41-year-old who had acute decreased vision for 10 days. This is not my case, it's from the website. So what I'm trying to do here is show you causes of, just to step back for a second, different categories of subretinal fluid, and then something in each case or 2 in each category. So you get a picture that is not all, so it's not all wet macular degeneration, it's not all central serous, and you usually can find the diagnosis. This was one of the more obscure ones. This is a nice picture though, so if you should see this. There's subretinal fluid, it's not sub-RPE in both eyes. And this is acute exudative polymorphous vitelliform maculopathy, which is probably an autoimmune. It's probably a paraneoplastic autoimmune, and it's rare. But I had one of these, and I got to do a discussion in Retina once on one of these for the case reports. This is like the only, not that they asked me, that's the only time they ever
Do you
asked
have
me.
a cancer?
That's right. Yeah, I think this person had cancer. So this is another patient with CRD. This serous retinal detachment, 71-year-old man, no vision complaints, 20/40 in the right eye, 20/60 in the left eye. And he comes in, the right eye looks normal, the left eye's got that line, which, that's a staphyloma. He's got a posterior staphyloma. And this is a scan through his macula, and there's subretinal fluid. There is an entity with the fluorescein doesn't really show much. There's sort of hyperfluorescence around the edge. The ICG doesn't really show anything. It's mostly dark. So this is probably not neovascular. This is probably a serous macular detachment associated with a staphyloma or dome-shaped macular or tilted disc. And this is sort of an OCT. So some of these, that's the thing with the SD-OCTs, they've been out for almost 10 years now. I think six or seven, it's more than 5. So some of these diagnoses are kind of new and they're being described, but there seems to be an abrupt transition in the choroidal thickness close to the subretinal fluid, maybe a large choroidal vessel, maybe there's scleral thickening in UVA. No, people aren't sure why this happens, but there's good visual prognosis, and treatment probably doesn't help. I have not treated him because he's not bothered. So his vision's perfectly good. We kicked this around. It's nice, we email each other. And there's the one suggestion on this, which I probably would try if I had to, is PDT. Is try to find a spot of thickened choroid somewhere and away from the fovea and PDT, and it probably would get rid of the fluid. And then the last category of subretinal fluid is CSF. So cerebrospinal fluid can cause subretinal fluid. So an optic CSF, optic nerve fit retinal detachment. There's an imperfect closure of the superior edge of the embryonic fissure. 1 in 10,000 people have these, which is not many. You can see them in children or adults. So I have a handful of older patients with sort of funny looking maculas where often you see it kind of coming off the nerve and there's something there. And I think And you can do an EDI through the optic nerve, and these sometimes are bilateral. And you look for other diagnoses. So this is a 10-year-old with vision loss. We watched for about 10 months with fluid under the macula, and the funny-looking intraretinal fluid there too. And this is the scans after a procedure was done, which I have. Hold on. Okay. So we have no financial interest. This is Dr. Eichenholz and I. So we happen to see two kids with optic nerve pit retinal detachments. You can see the nerve pit on the on the OCT. And what we did in each case the same day was a vitrectomy and then an inner retinal fenestration. And what this is you just take a 25 gauge needle. I didn't talk to the author, although I have been emailing him lately. And you just scrape the retina kind of gently by the optic nerve. And the idea is what that does is it creates a retinal defect that allows egress of subretinal fluid from under the retina into the vitreous. And it decompresses, and it worked beautifully. This was the one boy, and this was the girl. They were both about 10. One of the surgeons is me, one's Dr. Eichenholz. And what we do is just a vitrectomy, and then you just take a needle and just scratch it. It takes literally 10 minutes, and you're not violating the lens, you're not doing a gas bubble, you're not doing much, you're not doing a PVD, and you just scrape the retina there. You're not trying to transect the NFL, you're trying to just make a defect with the nerve fiber layer. And both of these patients did well. So this was the patient with the subretinal fluid, and then it goes away, and then it's gone.
What's amazing is you can't really...
How deep do you think you were? Do you have any idea?
Not
What's that?
very...
How deep?
Not much. You just kind of move in the retina. And that's why you got to see if you're even hitting it. So I don't know if Rick Spade published on 12 or 13 of these cases with a very high success rate. I emailed him. He said I could use his name on this. And he also was looking for the nerve scans, but just enough to kind of see the retina move. When you're rubbing it, you can see.
Like you don't see any choroidal blanching.
No, but you can see the retina rippling a little bit under high.
That's it?
Yeah, just like 2 or 3, and that was the procedure. That's edited. I mean, it's edited down to a minute and a half, but that was most of the procedure. Yeah.
Wasn't there a paper where some guy took the internal limiting membrane and tried to plug it?
Yes, that's just came out.
Is he doing the same thing?
Probably. He's probably creating a defect under it. I think this is the best procedure. I've done a gas bubble on these kids. I've lasered them. The laser doesn't really work, I don't think. The gas bubble and a vitrectomy probably works, but probably because you're disrupting the retina. This is very nice, and it's logical. It's a well thought out procedure. I really like it.
It came out beautifully. Yeah.
So vitrectomy. So he had 18 eyes. So vitrectomy for an interretinal fenestration. There were 18 eyes. 17 of 18 had resolution of subretinal fluid, and no recurrence of fluid over a pretty long follow-up. Yeah, 3 years. Because I was talking to one of my partners about this, and they said, doesn't that come back? And I said, no, if you look at the paper, it looks like it probably doesn't. So this is a nice procedure, and the families are all happy. Show video. There we go. So this is the whole presentation. So subretinal fluid, you've got sort of 6 categories: Masquerade, Vitreous, Retinal Vascular Disruption, Optic Nerve Edema, Choroidal Disorder, or Cerebrospinal Fluid. More important in a subretinal fluid case is probably disruption of the barrier more than the hydrostatic. It's probably not so much the hydrostatic, the pressure of the fluid, the hydrostatic pressure. It's more the oncotic that drives fluid inside the eye, and that has to do with the barriers. So this is a 77-year-old guy I saw about 3 or 4 months ago. He's really angry at me. He's had gradual vision loss in both eyes, and he has a weird history. 6 months ago, his vision got worse. His ears were clogged up. He got a Z-Pack. They got better. He caregives for older people, so he's exposed to all sorts of weird things. His vision got better last month. His eyes don't hurt, no pain on movement, and he's been using steroid ointment. So it's like this whole thing. His vision's not good. He's got 2200, 2125. Typical for these cases, he's got a cataract, so you can't get good pictures. So that's why these are the cases you don't see any confidence. But he's got this subretinal fluid, which is really funny looking. So he's got a cataract in both eyes. Those are the color images. The choroid's thick and unusual looking. It doesn't really look vascular. We've seen a bunch of choroidal images today. This looks more infiltrated in both eyes, and you can see the undulation. You can see the choroidal folds because there's not much room there. Things are being shrunk in. This is the autofluorescence, which doesn't really show you that much, and this is the fluorescein, which is a little tough, and then the ICG also doesn't really show that much.
Fluorescein showed you something.
Yeah, it shows it shows sort of a leopardy hyperfluorescence.
So what's the cause here?
We don't have a diagnosis yet. I think my best guess is it's B-dump. I think it's bilateral diffuse uveal melanocytic proliferation.
In response to?
Some kind of
That's what he
tumor.
doesn't have a cancer diagnosis.
Yeah.
That's why
Yeah,
he's really
yeah.
mad at me. And I've seen B-dump in the past, and it's rare, but B-dump, when you look at the literature, is almost always someone who has cancer.
But did his
They
interest
come
in the
in-
cancer workup?
He's not
or-
a-
Yeah, no, he's a
Unlikely to
guy.
have
Yeah,
ovarian.
long ovarian. That was one of the
Yeah.
tests. You guys that we were doing practice questions. One of the practice questions was with which tumors is B-dump most commonly associated?
And it is ovarian and what's the
Oh,
other
it's
one?
the ender. Yeah, ovarian, breast, lung. I think GIs.
So he had a PET scan and it was negative?
No, now he's doing the testing, but he's
Oh, yeah.
angry because
Yeah.
he doesn't want to. Because I asked him, I said, "Do you have cancer?" And he goes, "God forbid." And I was like, "Yeah." And then, so he didn't want to do that whole thing, and he didn't want the doctor. I called a doctor, called him, he hung up, and he said, "I don't want to see this guy."
Bilateral
So we're trying to get him evaluated, but I think it might, and I'll tell you later. So the case will, and the other thing is I'm trying to get his cataracts out so I can get better pictures. It could be uveal fusion, but uveal fusion, this looks so and again, there's not a lot on choroidal OCTs that I've seen. I'd love to see a review article on the choroid and OCT, because I think if you had a good review, this would not be uveal fusion, because it looks infiltrated. It doesn't look so much fluidy. But it could be the undulations are uveal fusion. And it does look kind of like uveal fusion. It could be lymphoma in both eyes, maybe, choroidal
What's
lymphoma.
it, the uveal fusion is very tricky.
Yeah.
It's Scott's, is
Yeah,
very
posterior
interesting.
uveal fusion.
But posterior, there's a group that doesn't have short eyes.
Right, yeah, they just
And
seem to be the
They
scleras.
just, and they are very tough to diagnose, and it takes a lot of courage. I mean, which resident helped me on the last one? Oh, it was awful.
Oh, did you do windows?
Yeah, I did windows. Yeah, and I did a window, and then I looked, and he still had a lot of sclera, so I cut down again, same spot, and took off another layer, and then I cut off a third layer.
Yeah.
Finally, I was seeing some uvea. I mean,
Yeah.
it was
It's
Did he get
scary.
better?
I mean, the amount of sclera was horrendous.
You got better? Yeah.
Well, I haven't seen them clear everything. They get rid of the choroidal right away, and the retina I think is getting better. You
Yeah,
know,
so that's
and
the
then
thing
you
is
see, and then when the fluid goes away, that's when you see the leopard spotting, and it's dramatic.
So this could be so that's what I'm thinking, maybe uveal fusion or beta. It looks to me kind of like beta.
Is he? He's older guy.
He's older guy.
But
And then the other thing is history.
because they look the same.
Yeah, his history was so weird. There's something, he had a long, and he also was about to go into back
Doesn't Give
surgery.
you more pigmentation.
Yeah, that's what Scott, yeah, we talked about it.
We
Typically,
talked
it's
about this
more,
on email,
it's more
right? Yeah.
clumpy, there's
Yeah.
usually more, the FAF is usually more striking, but the cataracts are getting in the way. of
Cataracts are the
everything.
way, yeah.
But that's why I told the cataract surgeon, I said, I want the cataracts out so I can see his retina. Being selfish. And the other thing is B-dump has rapidly progressive cataracts. So that's one of the, I didn't, until I looked at that, I didn't remember that. So
Right.
that's one of the hallmarks of B-dump.
I have a case that I'm following now where we don't have pigmentation yet, and I think the reason is he does not yet have subretinal fluid, but he's got horrendous choroidals in one eye and subclinical choroidals in the other eye.
Right. So yeah, it's a weird, and it's a very rare. It's hard. So the subretinal fluid is going to be somewhere on that list. So somewhere, if you see subretinal fluid, again, I got a 27-year-old girl right now with the subretinal fluid. I was sure her blood pressure was going to be up because I thought it was hypertensive, but it wasn't. And when you dug around, she has an allergy to cats. She tries to stay away from cats, but her new boyfriend has a cat that apparently has
Yeah,
fleas, and
good
she
for
was sick.
boyfriend.
And she was the one they called. So I think she's probably cat scratched too, but she could be any one of a number of things. But it's not infinite. So if you have subretinal fluid, it's not always macular degeneration. It's not always central serous retinopathy. There's a bunch of other things. And I think probably the trickiest one we've seen lately is that dome-shaped macula. It's kind of a weird one. Or the possible B-dump. That's the whole thing.